talks. Up next is Dr. Ganga Sundar from National University Hospital and National University of Singapore, who's going to talk with us about lacrimal microendoscopy.
Thank you, Kyle. I cannot show you such pretty pictures, but I'll try to do justice. So I'm going to talk to you about some new techniques that we've been adopting in our practice for the past several years, which is lacrimal microendoscopy as a replacement for external or endoscopy DCR. These are my disclosures, but no conflicts of interest. But for the youngsters, these are the books that you can read. So we all know about lacrimal drainage procedures, but there are newer things that's happening, and that's ELDR and dacroendoscopy. You can combine them with the various other adjuvant procedures itself. Yes, like Francesco mentioned, there's experience and evidence, and only time will tell what the long-term evidence is going to be. Just to draw attention to some of the legends who are created, and most of them are living with us. We lost Jeff Hurwitz after the last dacryology meeting in Greece, Athens, but we now have 3 living legends who have all contributed to how we practice lacrimal drainage surgery. Just a quick overview about NLD obstructions. We can be classifying them into anatomical obstructions and functional obstructions. Surprisingly, even sometimes for functional obstructions, we do the traditional bone-removing dacrocystorhinostomies. But one of the terms which has never really caught on is the concept of dacryostenosis, causing problems rather than just complete obstructions itself. And the treatment options, regardless of whatever you had, was a DCR, be it an external DCR or an endoscopic DCR. And to me, that's kind of mutilating surgery, although it's a surgery still I like to do when it really matters itself. And that's where learning from the masters, pioneers in the field really comes in. There's Emmerich from Germany, who really introduced the original microendoscope. Then finally Toru Suzuki, who's introduced a semi-rigid endoscope, and Ray Havati, who's now working with the new endoscope itself. So endoscopy is not new. I think Kyle opened up the session talking about endoscopy for the orbit itself. Endoscopy of the nose is not new for us. And what about endoscopy inside the tear duct itself? And that's where these lacrimal microendoscopes come in. There are numerous companies which are offering it. Storz has now discontinued their product. I use a polydiagnose when I'm doing these procedures in the under general anesthesia in the operating theater, or I use a semi-rigid FiberTech endoscope. I have not tried the Machida itself. In the past, we would never see what is really going on inside. And the only way of knowing what was going on inside was the dacryocystogram. So these are negative shadows. So they're looking at a shadow and interpreting what the human being looks like. But we now have potential possibility of visualizing various forms of pathologies, including polyps, tumors, dacryoliths, and complete obstructions, fibrosis, distension, so on and so forth. So this is an example of a real-time video of a lacrimal microendoscope. There's a huge learning curve really involved. But we are now able to see specific locations of obstructions, narrowing, fibrosis, purulent material, debris, foreign bodies, even punctal plugs that are placed and migrated down the system itself. And these are examples of various pathologies you can now, including broken stents itself. So you have to be now familiar with, just as how you have to be familiar with various landmarks, you have to be familiar with the way the lumen looks at various normal locations as well. So be a student of the normal before you go into student of pathology. But this is an example of a patent of the local lower end obstruction where you can see the stenosis is not complete, but enough that with intermittent swelling, you're going to have complete NLD obstructions. So we started off doing them in the operating theater and the general anesthesia, where we're doing now more and more under ELA, which is endoluminal anesthesia. So here's an example of a patient where we are showing diffuse dacrystenosis. You pass the punctum, which has to be dilated. You pass a microendoscope along the canalicus. Once you pass the common canalicus into the lacrimal sac, usually it's a distended space if it's a lacrimal sac is really swollen. Then you find your way down to the nasolacrimal duct until the lower end where you really see an obstruction. Here's an example of a patient where now actually there's a distended lacrimal sac, and this is where in the past, regardless of what the pathology was, regardless where the obstruction was, we were doing a one-size-fits-all dacrocystorhinostomy-like procedure. You can see the humongously dilated with multiple mucosal folds that you can go all the way down to where the obstruction is. And this is important not only to identify pathology, but if you're able to identify that most of the obstruction is way down below, these are the patients which lend themselves into good, successful endoluminal lacrimal duct recanalizations. This is a video which just won an award at the Asia Pacific Academy of Ophthalmology prepared by my fellow. I don't know if the audio works over there or not. I think this is a final frontier of lacrimal drainage surgery. For recording purposes, we're using this surgical video we did in the operating theater, but we're going to kind of give you a map of what we really do. We do an endoluminal anesthesia, and that's a 3-port microendoscope. We can introduce a third instrument, a drill laser if you want, but I tend to use a mechanical recanalization itself. And as you go down the punctum to the proximal and distal canalicus, you can see the various landmarks right over here. It's quite narrow, especially in patients who have chronic obstructions. Then you go into the lacrimal sac where it's nice and beautiful distended, and as you go down the nasolacrimal duct, you find where the pathology is. Once you find the pathology, this has a shaft which can recanalize, following which you can confirm patency. I use intraoral triamcinolone alone, and either I would use a balloon dacryoplasty or I would do a straight old-fashioned bicanalical intubation itself. So various forms of recanalization exist. To me, mechanical recanalization is still the way to go. There are numerous advantages with this procedure. Like any endoscopy procedure, the downtime is very minimal. Success rate may not be as high as a conventional external endoscopic DCR, but there are specific patients where I think there is a definite indication for this rather than a mutilating procedure. You can, in the interest of time, I'll probably start right over there. But you have to understand lacrimal drainage pathology. This is not a procedure for everybody. It is not a procedure when people have secondary acquired lacrimal duct obstruction. This is not a procedure where you may have malignant tumors inside. But in patients who have the typical pando with lower or inferior end NLD obstructions, this is a good alternative, and this has completely changed the spectrum of lacrimal drainage procedures that we do in occupiers. So in summary, I think it's now important for us to understand, familiarize with the new technologies which are really available. This is minimally invasive. I think the only person who now does this is somebody in Philadelphia or Pittsburgh who's starting to do this, although I know it's not considered a standard billable procedure in the United States. These are procedures which are quite popular in the Asia Pacific and the Far East, and I'd like to take this opportunity, those of you interested in orbital meetings, to join us in October. Thank you very much.